Okay, I want to welcome you again to today's lecture. My name is Geoffrey Mtale, and today we are going to discuss about the International Academy of Cytology, the Yokohama system for reporting fine needle aspiration for breast biopsy, and that's what we are going to discuss about today. For those who need to contact me after this lecture, my number is just right there. It is the very number which is on WhatsApp, so you can easily contact me. And again, I want to thank you for always liking, sharing, and commenting on my slides on YouTube. I encourage that you subscribe so that next time when I upload a new video, you'll be able to see it. Please press the like button, and then subscribe. Okay, so I think let's move forward and continue with our discussion. So basically, the International Academy for Cytology, this is a system which was set in place particularly to harmonize the communication reporting between the pathologist and then the clinicians who are managing these patients. Its major intention is to standardize the mode of reporting so that there is uniformity in reporting and categorization of the different lesions across the board in the world, so that it can be universally accepted and understandable, the interpretation making it uniform for easy communication and management. So the International Academy of Cytology system for reporting breast fine needle aspiration, or abbreviated as FNAB, was developed in a meeting at the Yokohama International Congress of Cytology in the year 2016, and this was done by a group of stakeholders which included the cytopathologist, the radiologist, and then clinicians who were managing breast lesions. So in this meeting, modifications were made, and these were based on the peer response reviews which were received to an international questionnaire which was carried out in the year 2018. So the aim of the system were to standardize and improve the reporting of breast cytology, and to establish best practice guidelines, to improve training in performance and interpretation of breast cytology, clarify communication between the cytopathologist and the breast clinicians, and to link this reporting system with patient management so as to facilitate optimal breast care. The intention of it all was to have clear communication, and this would guide or would communicate properly with the clinicians managing the patient, and the patient can get proper management. So in this review, emphasis were made on the importance of skilled biopsy and smear making techniques, and this was done to optimize the quality and enhance the FNAB diagnosis. We are all aware that results that we get will actually be determined on the quality of the sample we prepare. So here emphasis is so much put on the quality of the biopsy we get and the technique of how we make these smears. This is very important. So key elements to breast FNAB procedure are the careful selection of a line of approach for the needle, fixation of the lesion by palpation or palpation around an ultrasound guided probe, and this will help you to see clearly that the needle is actually in the lesion, and then rapidly perform the puncture of the lesion using the rapid movement of the needle into and out of the immobilized lesion. We do not want to keep the needle for so long in the lesion or make several trials when you're trying to aspirate, because this eventually will bring in a lot of blood into the smear, and this will obscure cells, thus rendering your smear incompetent and unsatisfactory for evaluation for that regard. So ultrasound scan, this provides guidance and visualization of the needle tip throughout the procedure, and this can guide you very well and to really confirm that you have aspirated the lesion yourself. So in this procedure, it's advisable that both air-dry regimes are stained. Direct smears and alcohol-fixed Papanicolaou stain slides should be prepared by splitting the material obtained on each needle pass. So whenever you aspirate the sample, it is better that you make 2 slides, and one should be for pap staining, and then the other one will be dry stained, and then air dried and stained with GMSA. So routine rinsing of the needle or otherwise separate passage for cell block preparation to enable immunohistochemistry, that is for prognostic indicators, is also very important. You remember we are going to make smears, and for this case these smears will be stained. So to retain some samples is very important, which can be used for other studies like immunohistochemical studies. So either we rinse the needle to get samples where we shall make the cell block, or a separate needle pass is important to be made, and then we reserve this for auxiliary test, like for example the immunohistochemical test and other tests which may be needed by the cytopathologist. So under this reporting system, the reporting is categorized under 5 subheadings. We shall have 5 categories under which we shall make our reportings for breast cytology. So the ISC Yokohama system has 5 categories that can be stratified by their risk of malignancy. And the first category is one which is regarded as insufficient or inadequate. We shall look at the criteria for it being rendered inadequate or insufficient. And then we have the benign, atypical, suspicious of malignancy, and then malignant. And in this we state that the standard structured report should state one of these descriptive terms as a diagnostic headline. So when you're reporting, at least your report should be under one of these 5 categories. You either report the smear as being insufficient or inadequate. It is either benign, and then we shall also see that if we are reporting as benign, we shall also be able to conclude and mention the conclusive diagnosis of the lesions we have identified. Like for example, if you are saying it is benign, it is important also to state that it is either a fibroedema or a cystic lesion or a fibrocystic lesion for that case. So going forward, the laboratory where we work or where you're going to be working should actually choose either to use insufficient or inadequate. We cannot use both at the same time. So by the policy you set in your lab, or by the policy set by the lab where you do your practice from, it is important that you choose between insufficient and inadequate. You choose the term that you will be using consistently throughout your reporting. A fine needle aspirate biopsy should always be correlated with the clinical and imaging findings in the triple test. When you talk about a triple test, in this case we are referring to where we are having both the clinical diagnosis, we are looking at imaging, and then finally we are looking at the cytological analysis and the morphological evaluation of disease cells in the lab to see if there are some significant atypical changes on the cells. And we are saying that if there is any discrepancy, then the FNAB should be categorized by the material on the slide and not as non-diagnostic based on the discrepancy between the clinical findings and maybe the imaging findings, if imaging is available. So in this situation, the report should contain a statement that the material may not be representative of the lesion seen on imaging, and that further biopsy by FNAB, or usually the core needle biopsy, is required. And this is recommended that we need now to confirm, because we have a discrepancy. Probably clinically it was different, maybe it was a benign lesion, and probably on imaging it would have been suspicious for that case, but maybe when you did the microscopic evaluation, it could have been malignant for that case. So once you report that based on what you have seen under the microscope, you must put a statement indicating that it may not be representative of the lesion seen on image or clinically evaluated. So the majority of atypical cases, benign proliferative lesions, and the majority of suspicious malignancy lesions are in situ or low-grade carcinomas for that case. So the report headed by a category term and then include a brief cytological description, noting whether possible the presence or absence of a key diagnostic feature. So we should not just report and we say it is either benign under the heading, no, that's not enough. But under the heading, when you report that it's benign, then it is advisable that we go ahead to include the brief cytological description that you think justifies your conclusion that it's benign. If there are some atypical cellular changes that you have identified, then you report them. Those features will be very important. So this description is followed by a conclusion or summary in which the cytopathologist should give us a specific diagnosis of the lesion. Like for example, like I mentioned before, it's always important not to simply say benign, but if you can go ahead to conclude and make a diagnostic conclusion that probably you have seen a fibroadenoma. That will be very important. Or if the diagnosis is uncertain, then provide the most likely differential diagnosis for that case. So ideally, both the imaging and the cytology findings should be as precise as possible to maximize the specificity of the triple test and to highlight any discrepancies, just in case there is any. And finally, a category number 1, 2, 3, or 5 for which corresponds to insufficient, benign, atypical, suspicious of malignancy, and malignant respectively can be stated in the body. You will find that in some literature, these categories begin with C. So you will find when some other literature are beginning with C1, C2, C3, C4, going on, but we are saying these are reported irrespective of the headings we mentioned or the categories we mentioned. Actually, if we add C, this will be referring to category 1, category 2, category 3 going onwards, which represent insufficient, benign, atypical, suspicious of malignancy, and then malignant lesion. So the category number is not to be used as a replacement for the actual diagnosis of the descriptive category terminology. So even when we use the numbers, we should actually make sure we include the category description. Yes, the category distribution should be there. Don't just say C1 or don't say 1, but actually the title, the headings we mentioned before, like for example, insufficient for evaluation, which is number 1, should be there. You don't just say 1. And if it is benign, don't just write 2, but actually you need to put the heading. So the aim of utilizing consistent categories and a clear diagnosis is to enhance communication between the cytopathologist and the clinician, and this will be uniform across the countries across the world, that even when you receive a report from a different location of the world, you can be able to interpret what it is and manage the patient well for that case. So going straight forward to category 1, and this is what we are putting under insufficient or inadequate, and by definition this can be referred to as insufficient given on the fact that the smear is too sparsely cellular or too poorly smeared or fixed to allow a cytomorphological diagnosis. You remember our major interest here in this slide, we want to look at the cellular morphology. We need to look at basically the cellular morphology. So if there is anything which obscures the appearance of the cells and their clear morphology, and then the number, because when we are doing evaluation is cytology or histopathology for that case, we don't look at, or we don't judge by simply a single cell, but whatever conclusion we make should be representative of the entire tissue. So we need at least a certain number of cells to have certain significant features or typical features that we can be able to conclude. So we cannot only see one normal cell in a field and then conclude. That's why we need a good number of cells to help us make a judgment properly. So FNAP smears are regarded as adequate or inadequate based on the assessment of the material on the slide. So this is very important. That's why we're emphasizing the importance of sample collection and how you prepare your specimen. So if there is a sufficient material on the slide to reach a diagnosis, then the FNAP is characterized based on that, and it can be called sufficient. And if there is no enough cellular material, then it can be regarded as insufficient. But however, if the triple assessment is discrepant and the FNAP material does not explain the imaging or clinical findings, then the FNAP report should contain a statement that the material may not represent the lesion, and further test will be needed, like the core needle biopsy for that case to confirm. So under the category for adequacy, we need to look at the criteria, and then we see under which criteria would we regard the slide as being adequate. So at least there should be 7 clusters, each containing about 20 or more epithelial cells, along with the presence of myoepithelial cells. So if material is sufficient, then categorize the FNAC on the basis of that material. But however, this is not the only criteria. If the cytological findings correlate with clinical and imaging findings in the triple test and are sufficient to make a precise diagnosis. And what we are referring to, or what we are meaning is here now, is that fine, you may not have seen the clusters consisting of 20 or more epithelial cells for that case. But if according to the clinical and the imaging categorization of the lesion, they are actually making a diagnosis that the lesion is malignant, but then for you don't see the 20 clusters or the 20 cells, but you can see some cells which have actually malignant reactions, then you go ahead and qualify the smear and report respectively. So how do we manage samples when we don't probably get the samples to be adequate, when the smears don't qualify to go for evaluation? What happens next is that if the insufficient smear is due to a technical issue, we recommend that you repeat the FNAC to maximum of 3 times. Yes, you repeat the FNAC to a maximum of 3 times only. And if it is insufficient due to lack of sufficient cellularity to explain the clinical or imaging expect diagnosis, then it is also recommended that you repeat the FNAC, you aspirate again. And 3, if the lesion is benign on imaging, then what you do is to follow up after 3 to 6 months. And then number 4, if it is indeterminate or suspicious imaging, then it is also advised that you repeat the FNAC, or the core needle biopsy is mandatory. And lastly, if no imaging is available, then what you do, you correlate the clinical and the FNAC findings and then repeat the FNAC. So now we move to category 2 of breast cytology reporting under the Yokohama system. And by definition, category 2 is when the breast FNAP diagnosis is made in the case that we have an unequivocal benign cytological features which may or may not be diagnostic of the specific lesion. So we are saying that in most cases, if the lesion is benign, then a breast FNAB histological diagnosis may not be actually required if it is benign. And a benign FNAB diagnosis with negative clinical and imaging findings is regarded as sufficient diagnostic workup, and if still negative at 6 to 12 months, then the benign FNAB is regarded as correct, and there may be no need for carrying out other investigations. So we need to look at the morphological features of benign lesions. So what we expect to see in our slide, we shall see the predominance of large cohesive 3D tissue fragments and flat monolayered sheets consisting of evenly spaced ductal epithelial cells with myoepithelial cells creating a bimodal pattern, as well as the bipolar nuclei representing stripped myoepithelial nuclei in the background. So what is most important here in this case is that if we are able to see the presence of myoepithelial cells in our side, and this most of the time at the periphery, so this is a very good indication that we are actually looking at a benign lesion. So we have this image here before us, which is actually showing or illustrating the benign lesion, and in this we appreciate the ductal epithelial cells, which are arranged in a monolayer with good cellular plurality and interpassed myoepithelial cells, and this was a diff quick stain. So maybe to some of us we may not be well conversant or not be able to identify what the myoepithelial cells are, we have these hyperchromatic cells. They are oval in shape and smaller than the epithelial cells. So these are the myoepithelial cells. So the presence of these myoepithelial cells in any lesion, they are significant, and these are just enough for us to conclude that actually we are looking at a benign lesion. So once you see many of them, then you are identified that you're looking at a benign lesion. So some of the common benign lesions, for those who actually attended my previous lecture when I was actually talking about the benign lesions of the breast, we talked about some of these lesions, and I'm going to refer you to my video. You can look for that video on my YouTube handle where I was explaining the benign lesions of the breast, where we shall have it full details, but for the case of this presentation we shall just mention through and not go into details. But we have acute mastitis, breast abscess, granulomatous mastitis, which could be due to TB and other non-specific inflammatory processes. We have foreign body reactions such as with silicone and fat necrosis, and then we also have cysts with apocrine sheet in a proteinous background. We looked at this. You can look out for this on my YouTube, and then you will see the proper explanation of the benign lesions of the breast. Then we also looked at the fibrocytic changes with apocrine sheets and small cohesive ductal epithelial tissues fragments in a proteinous background. We also looked at slide background. So when we talk about the proteinous background, I think you can also look out for my videos when I was talking about slide background, and then you'll see how we differentiate and between the proteinous background, the cystitic background, the inflammatory background, the mucinous background, and other backgrounds, as we shall see in that lecture, which is uploaded on YouTube also. So before we look at the abnormalities, it's always very important to understand how normal features are. So before we look for the abnormal features of the breast cellular appearance, it is always good to appreciate how the normal cells of the breast actually look like. So when you see anything which deviates from what you have seen as normal, probably that would be pointing to some atypical changes. So this for this case, these cells we aspirated from a small terminal ductule. These cells we aspirated from the smaller terminal ductules, and in this we appreciate the small epithelial tissues fragments showing large ductal nuclei with bland chromatin and smaller oval dark epithelial nuclei with bare bipolar oval nuclei in the background. Yes, we talked about the myepithelial cells in our previous slide. Now here, what we also need to appreciate that in breast cytology, the size of the cell is also going to differ based on where the cells are got from. So in these small ductules, we're going to see small cells, and for bigger ducts, we shall also have bigger cells for that case. So these cells are small because they have been picked from the small ductules. And when we quickly look at this, we can also see, we're going to talk about the bipolar nuclei background. Some are isolated. We have this cell here, which is with the bare nuclei. Actually, we cannot actually tell where the cytoplasm. It looks to be bare nuclei. And then we get to see some epithelial cells. If we look here, we can see these small round to oval hyperchromatic cells. We have this one here, we have this one here, we have this one here, some is here, and there is others here. So this is a very normal illustration of a breast tissue. So for those briefly looking at a few, for those who missed last time's lecture probably, this is a typical cystic background or cystic lesion, and in this we appreciate the site of metaplastic apocrine cells and histiocytes and multinucleated histiocytes in the proteinous background. So this background is typically proteinous. Let me get a pointer here, and then we point to some few cells. So we have metaplastic apocrine cells, which are larger than the normal epithelial cells. So these are apocrine cells. And then another distinction we have is that sometimes these apocrine cells have eosinophilic cytoplasm, and I think there are some others here we can see. These are apocrine cells, and when we look at the cytoplasm, it is a little bit eosinophilic, and their size is bigger than the normal breast cells. And then we also appreciate the histiocytes. These histiocytes here, which could be actually multinucleated. So we have actually this one with the 2 nuclei. This one has 2 nuclei, and then we have another one here which also multinucleated. And then what is the other significant figure on this is that they have the foamy appearance. When you look at their cytoplasm, the cytoplasm is foamy. It looks like a foam, and it gives its name the foamy appearance. And this is very typical of cystic lesion. So how do we manage such cases? So number one, we need to review the clinical and imaging findings, and if the triple test says it's benign, so there is no further biopsy which is required, and the review will depend on the nature of the lesion for that case. And if the clinical or imaging is indeterminate or suspicious, then it is advisable that we repeat the FNAC or proceed to core needle biopsy. So category 3 is the atypical. So by definition, they are atypical in breast fine needle aspirate biopsy is defined as the presence of cytological features seen predominantly in benign processes or lesions, but with additional features that are uncommon in the benign lesions and which may be seen in malignant. So it is in between there. It has features which could be of benign, but still it has some atypical features. But these atypical features are not that significant enough for us to conclude and rate it to malignant reactions. So cytological features that we may encounter is high cellularity, and then number 2, we may have increased dispersal of single intact cells, which is very common, and then we also have enlargement of and pleomorphism of nuclei, presence of necrosis, mucin. We may have complex micropapillary or cribriform architecture of the epithelial tissue fragment. So we encounter these cytological features. And look at this image of category 3 of the lesion, where we're talking about the atypical one. So here we are seeing the lesion which is showing the slight loss of cohesion of cells with mild nuclear atypia. So in most cases, when most especially in malignant cases, the cells will always lose their cohesion and become discohesive and get sparsed, in addition to other features of getting enlarged nuclei and having increased cytoplasm to nuclei ratio, and having coarse nuclei and other features. So all these are significant, but for this case, well, we have some atypical changes. When we look at this, we can appreciate some little bit of discohesion in this, but then they are not significant enough to make us draw conclusions that they are really malignant cells. If you look at their chromasia, they are not that hyperchromatic, in as much as there is increased chromasia to a certain extent, but we cannot conclude. We also have another image here, and this is of the epithelial sheet, which is showing the nuclear variation in size and chromatin and shape. There's multinucleation and infiltrating histiocytes, which could be regarded as atypical, but a low nuclear to cytoplasmic ratio. The apocrine cytoplasmic differentiation, histiocytes, and the proteinous background are present, which actually excludes it from the category of being malignant. So it has some features which are of atypical nature, but other features are not sufficient enough for us to draw conclusions that actually this is a malignant lesion. So we go to category number 4, and in category number 4, this is where we have it suspicious for malignancy. And for us to categorize this lesion that is suspicious of malignancy, then it should have at least the presence of some cytomorphological features which are usually found in malignant lesions, but with insufficient malignant features, just like I've been looking at the atypical one. So this could be sufficient either in number or quality to make a definitive diagnosis of malignancy. So the type of malignancy suspected should also be stated where possible. And we are saying that the cause of a suspicious of malignancy diagnosis are similar to those of an atypical category and include technical problems related to the skill of the operator performing the FNAB, making smears and handling the material, the experience and interpretation of the cytopathologist, and the nature of the breast lesion. So this category is a little bit confusing, and it may be hard to draw conclusions between the atypical and then the suspicious of malignancy, because they share some features. They have some features of benign, and then they have some features of malignant, which are not enough for the cytopathologist to conclude that actually this is a malignant lesion. So the cytologic features of proliferative lesions and low grade or in situ carcinoma overlap, and great care has to be taken in assessing smear patterns and nuclear atypia if we are to draw good conclusions. So we have an illustration on the slide, and it is showing to us the dispersed single cell, showing the eccentric cytoplasm and hyperchromatic, moderately pleomorphic nuclei with considerable smearing artifacts and blurring of chromatin, which could be categorized suspicious for malignancy. So if I get my pointer here, we see the nuclei pushed on the side. So this is what we're referring as eccentric nucleus, because this is a cell, but we see the cytoplasm in one side and then the nuclei is pushed. This is also a cell, but the nucleus is pushed on the side, also the rest of the cells. So even when we look at this one, it has some features like what we've been mentioning. If it has the eccentric nucleus. This is one of the considerations we look at. But again, when we look at the cytoplasm nuclear ratio, it's not that much enough, it's not big enough to make us draw conclusions that actually this is malignant, so it is just suspicious. Then another thing we looked about was the hyperchromasia. Yes, if you look at these nuclei, they are staining darker, so there is some level of hyperchromasia there, but not that much enough to make us conclude. Then we have another characteristic here, which of moderate polymorphism. Yes, we can appreciate the different shapes, the different sizes of the cells. They are not uniform, yet they are supposed, breast cells are supposed to be of the same size, but these ones are not actually of the same size. There is a lot of polymorphism which were actually appearing, and then there is considerable smearing artifacts. They look to be smudged, like spreading across, trying to like portray necrotic background, but actually they are not. So with these features which are not conclusive enough, we categorize this as being suspicious. So we have another image here, and in this image here we can appreciate the dispersed single intact cells with large hyperchromatic polymorphic nuclei and occasional prominent nuclei, and this is juxtaposed to the ductal epithelial tissue fragment, which is upper. Actually, in this slide, it's divided into two. We have the lower part here, and then we have this upper part. So we can see the dispersed single intact cells with large hyperchromatic polymorphism nuclei and the occasional prominent nuclei, which is juxtaposed to the ductal epithelium tissue fragment of the upper. So this is the upper layer, and then we have been talking about this one with enlarged nuclei. There is a lot of polymorphism here. When you look at these cells here compared to these ones, these cells are enlarged. There's a lot of polymorphism here, and there's a lot of hyperchromasia there. And then another thing which is very important when you look at this, there is a loss of cohesion in the lower part. So this is a cohesive pattern. And then we have myoepithelial cells in the upper cells of the ductal epithelium. So we have these myoepithelial cells which are representative of a benign or normal breast tissue for that case. Yet when we look at the one we are calling suspicious for malignancy, we don't actually see them, or we have just a few, like we have one here, and probably this is also another one, yet there are many in the upper portion. So these are with the regular ductal nuclei and the plentiful oval dark myoepithelial cells that we have already talked about there. So the decision to call this lesion carcinoma or to categorize it as suspicious for malignancy is because of the presence of a benign component, and this will depend on the amount of malignant material and the confidence of the reporting cytopathologist. So this is suspicious, and then one said we can really call it suspicious because of the presence of these myoepithelial cells, in as much as we are seeing a lot of atypical changes down here, but still we have other features which do not allow us to conclude and call it malignant for that case. So another category is category 5, and this is the malignant category, or what would also denote as C5. So by definition, a malignant cytological diagnosis is an equivocal statement that the material is malignant, and the type of malignancy identified should be stated whenever possible. So we don't only just say it is malignant, but then we must be able to go ahead and conclude with the malignancy we have identified, either it is ductal carcinoma or it is lobular carcinoma for that case. So the malignant diagnosis should only be used when there is full constellation of cytological findings and no discrepant features. So before we go to draw conclusion, we must have really appreciated, looked at all the features, and conclude that these are really malignant reactions and this is a malignant lesion. Because any mistake made reported as malignant, you have to carry their consequence on the patient, which among others may even call for mastectomy, and this is something serious if it's done on a patient when actually they don't have cancer and they end up losing their breasts. So we look at the cytologic findings, and in this case we shall have high cellularity, we shall have prominent dispersal of single cells, crowded tissue fragments with overlapping nuclei, we have nuclear enlargement, anisonucleosis, pleomorphism of the nuclear margin, size and chromatin, we have hyperchromasia, we shall also experience the prominent nucleoli, tubular architecture of epithelial fragment, intracytoplasmic lumina in atypical epithelial cells, and elastoid fragments. And lastly, we shall also see the presence of stromal fragments infiltrated by carcinoma in breast smears resembling small fragments seen in core needle biopsy, is as being categorical evidence of invasive carcinoma, though sometimes on cytology it is very difficult to determine whether the cancer is invasive or not invasive based on cellular changes. So it's always advisable that we do a core needle biopsy, or we do a histological tissue examination to really identify and categorize it as either being invasive or non-invasive. So we have an illustration here of a category 5, and in this we can appreciate the carcinoma, which is in a fraying discohesive tissue fragment with high grade with enlarged pleomorphic nuclei showing irregular granular chromatin, and the nuclei are sometimes visible. So when we look at this image here, it is typical of carcinoma. This is real cancer. We can see the nuclei are enlarged. Actually, this nuclei also we can appreciate the nuclear horror in some of these cells. It is fragmented. There is discohesion, which is very really prominent. There is polymorphism. The nuclei really are taking up different sizes. Irregular granular chromatin. When we look at the chromatin here, this is really irregular. It's not fine yet under normal circumstances. We are supposed to see fine chromatin in the nuclei, but this is really coarse. And then we can see some nucleoli in some cells. Yes, like this one we can see the nucleoli. Even this one we can see the prominence of the nucleoli among other cells. So this is typical of malignancy, and with the confirmation of that we can go ahead to report and we say this is a malignant lesion. So we also have another image illustrating to us how the carcinoma can be identified. So under this we can see the carcinoma with the intermediate sized cells, mild enlarged, mild polymorphic nuclei, and we need to note the comparison of size to the macrophage nucleus, which is on top. Actually, let me point on it. Make it the pointer, and then we so the macrophage we are talking about is this one at 12 o'clock. This is a macrophage here, you can see. And then we are saying, and the eccentric cytoplasm containing an occasional virtue in some cells, like this one here, we can have which containing a virtue. This is an eccentric one. This is a cell containing a vacuum, so we can appreciate this one. It's a very good example of the cell we are really mentioning. So in this one, this is also, it has those atypical reactions which we can actually use to conclude. We can appreciate the mildly enlarged cells. For sure, when you look at these cells, they are enlarged. There is polymorphism. When we look at the shape of this one, it's not the shape like this one. You look at this one, it is contoured, the margins are really take up different shape. This one is rather oval, this one is a little bit round, others are too big, like this one is really enlarged. Then this one is more this is hyperchromic, even this one is hyperchromic, and with many other different changes. We look at these cells, they are really very regular. Look at this one, so this one have really typical reactions which can make us conclude that they are really malignant. So it is recommended that the type of malignancy be mentioned or at least suggested in the report. It is also recognized that this is not always possible, and lesions such as polymorphic lobular carcinoma are not distinguishable reliably from high-grade invasive carcinoma, and no special type for that case may be given, but we can suggest the differential diagnosis for that case. So the most common type of carcinoma which can be suggested in a breast FNAB cytology based on their cytology characteristics are no special type, and these are ductal, lobular, mucinous, tubular, and metaplastic carcinomas. So for cases where we have difficulties in drawing conclusions in which type of really carcinoma has been identified, it is important that we do auxiliary tests or auxiliary studies such as the icadarin for lobular carcinoma, which can be applied to cell blocks or liquid-based cytology. And it is very common that there is less common carcinomas that might be suggested or diagnosable based on their key cytological features with or without auxiliary test studies. So with the medullary features like adenoid cystoid carcinoma, carcinomas with apocrine differentiation, carcinomas with the neuroendocrine features, and the carcinomas with the osteoclastic giant cells, it is sometimes important that we do the auxiliary test to draw conclusions. So also malignant lymphomas, angiosarcomas, and some metastatic carcinomas and metastatic melanomas to the breast can be diagnosed for that case. So here we have another image which is illustrating to us and it is showing us the dispersed single cells and these cohesive small tissue fragments of intermediate sized cells with a high nuclear cytoplasmic ratio and moderately enlarged and mildly polymorphic nuclei with a small nuclei in the fibrillar mucinous background. So starting with the last characteristic, this is what we are talking about, the mucina. We can appreciate the mucin, and this is a mucinous background. I would still refer you to my lecture when I talked about slide background, then we shall be able to appreciate the different backgrounds. So away from that, when you look at these cells, yeah, these cells have malignant reactions. These are typical malignant reaction. There is increased nuclear cytoplasmic ratio. So when you look at some of these cells, they have occupied the entire cell, and we can hardly see the cytoplasm. We can only see the nuclei occupying the entire cell. There is increased polymorphism. The cells are not of the same size, not of the same size, and the nuclei is sometimes the nucleoli can be seen, and we talked about the fibrillar mucinous background, which you can also see. So just like we said, it is important to talk about the auxiliary test, and because this one will help us actually conclude and in determining on which exact diagnosed lesions we have really come up with in terms of malignancy. And in this case, independent of the preparation used, the FNAB or the breast cytology provides good and reliable material for auxiliary studies. So this material can be found in the erectus smears fixed in alcohol with the pap stain, or H&E, or air dried and stained with the GIMSA or similar stain, as well as in liquid-based cytology preparations and formalin fixed preparations, embedded cells blocks. So the ancillary studies include immunohistochemistry and immunocytochemistry and molecular techniques which can be employed to study some staining characteristic of certain special markers which are characteristic of specific cancers. So these ancillary techniques are of value in specific situations that include diagnostic difficulties. For example, we talked about some lesions being difficult to differentiate, and for example, utilizing the epithelial cell markers on cell block material in atypical and suspicious lesions. So this will help us when to differentiate between the atypical and then suspicious using the epithelial markers. So when we find epithelial markers positive, then that will mean that those are really atypical and not suspicious. So we can also use immunohistochemistry on cell blocks for the prognostic and predictive markers, like for example estrogen, progesterone, and HER2 receptors in cytohybridization for HER2 on cell blocks, and this will determine this will help the physicians and clinicians to determine which kind of treatment will be appropriate for this patient. Immunohistochemistry for determination of the primary site of metastasis or metastatic lesion is also very important, because like we mentioned, the breast, we can also find some metastatic cancer, possibly from the lung. So when we do some immunohistochemical tests, we can be able to really determine the primary site of the lesion, whether it started from the lung or from any other part of the colon of the body. So that's also very important. And the study of prognostic and predictive markers in metastatic breast cancer setting is also important. As we conclude, we need to appreciate that the AIC or Yokohama system for reporting breast FNAB cytology defines 5 categories for reporting breast cancer. So these are points we need to take home. And the categories effectively stratify the breast lesion by their arm and provide guidance with management algorithm for each category. That is also very important to take. And we need also to appreciate that each category has a specific recommended term, and in the case of inadequate or insufficient, choice must be made on which term we are going to use, either inadequate or sufficient, but we cannot use both. So the system also, we also appreciate that it emphasizes on the crucial importance of high quality performance of the fine needle aspirate biopsy procedure and of making direct smears, because the quality of the smear you make will determine whether it will be evaluated or not, and will also determine how easy the slide will be evaluated. And this brings us to the end of our today's lecture. I want to thank you for watching the video, and I want to encourage you to like the video. Don't forget to like, share, comment, and then subscribe, so that next time when I upload another video, you will be able to see it as quickly as possible. Otherwise, I want to thank you for attending today's lecture. This brings us to the end, and I wish you the best of your time.